I want to first of all thank all of you and thank our panelists, thank our content experts. I think people will continue to join in this first few minutes, but we want to welcome all of you statewide, here and far, to this town hall, probably the first of many, as we begin to look at the real impact of what vaccines will do, particularly in underserved communities served by our community health centers across Massachusetts and across this country. The development of these vaccines brings us tremendous hope, but we do have a long road ahead of us. Today's forum is the first of many different tools and opportunities that will ensure that we have information all through our health centers and all through our communities to ensure that the information needed to be communicated for safety and efficacy of COVID-19 vaccine with our patients in our communities is realized. I also want to thank my own league team, who has been working tirelessly on behalf of underserved communities and in eliminating health disparities across this Commonwealth. I want to thank the Commonwealth of Massachusetts and the federal officials who have assisted health centers greatly in aiding and abetting our work. But I also further want to thank my successor, Michael Curry, who has stepped out into the forefront to become a major force on the diversity and inclusion of understanding the potential of these vaccines and the education that's going to be needed to overcome hesitancy in communities we serve. Please welcome my successor, Michael Curry. He'll take you through the program. And once again, to all the panelists, thank you so much for joining us. Michael?
Thank you, Jim. I'm hoping that folks can hear me. It is an honor and a privilege to follow Jim Hunt. As anyone who's been in this movement and in this work for a long time knows, Jim was really the architect of the health center movement here in Massachusetts. So I want, if we could, and this is impromptu, please at your seats as you are joining us virtually, give a round of applause to Jim Hunt for his many years of service and his great legacy. So I'm going to jump right in. I think before we get started, again, thank you, Jim. I want to welcome everyone. What's on my mind right now as we get started is the fact that over 300,000 Americans have died from COVID-19. And I just want that to sit with you for a second. 300,000, over 11,000 just here in Massachusetts. I sometimes think we get weathered to those numbers, but I want to remind us as we set the context for tonight's conversation that lives are being lost. That quite frankly, Black and brown lives are disparately lost to COVID-19. And that will really give us the urgency of this conversation tonight around vaccines. Before we get started, we'd like to have you participate in a quick poll to help us get a sense of the roles you play at your various health centers. And if you are joining us, but do not work at a health center, we will share the results with everyone. So I'm asking you now to please take the poll that is on your screen. This is the fun part of Zoom, as we get to do a little interactive with you tonight. I'm asking you to please take the poll. We'll leave the poll up for about 20 seconds while people participate. Okay, thank you. I want to thank you again for participating and taking that moment to participate in the poll. Today's town hall is part of a broader vaccine preparedness initiative that the League has launched across education, operations, and communications. The operations side of receiving and distributing the vaccine is being addressed through a weekly peer-to-peer call organized by our clinical team, led by Susan Dargan-Hart. The communications piece is being developed with the help of a poll which the League launched with the Museum of Science to gauge Massachusetts residents' knowledge about the attitudes towards COVID-19 vaccine, which hopefully most of you have seen. And through your efforts, such as feedback from this town hall and work with the State Department of Public Health, which is launching a statewide campaign that we hope to amplify and enhance in the communities we serve. But today is all about the education piece and empowerment. Empowering all of you with the information you need to then empower your patients and make important decisions about this life-saving vaccine. To that end, we will be focusing on the development, safety, and efficacy of the COVID-19 vaccines today with our panelists who have deep knowledge on how vaccines are developed and how they work. Please keep your questions to this topic area. That's very important. Please keep your topics related to that subject matter. Let's start with some pretty promising news. The poll I just mentioned showed that a majority of Massachusetts residents plan to get the COVID-19 vaccine. However, most want to wait until others have gone first. It also shows that across all groups, doctors are the most trusted source of information about the vaccines. As you might imagine, there is a drop of 10% between whites and communities of color when it comes to getting vaccinated right away. So an important first step will be to have physicians reach out to Black, brown, and immigrant patients to address their concerns. I want to make sure we're showing the first slide. So you should see in a second the first slide we want to show tonight. Again, we're only going to give you a snapshot from the Museum of Science Mass League Community Health Centers and Mass Inc. poll. But it's very important as we try to figure out a strategy on how to communicate with our patients that people take the time to actually read the entire poll. I'm going to talk while we pull up those slides, some interesting things that I thought from the slides. One, we found out that women, particularly women of color, have a less readiness about taking this vaccine than the broader community. And I've been asked in the media, and Karen O'Toole, who does our public affairs, knows this question comes up often. Why such a hesitancy among particularly African-American women and Latinx women? And the way I describe that is I think about my own personal family and my mother, many women in our communities are the patient navigators. They're the people who make that decision about what the right course of treatment is with our physicians when we're children, with our families, if it's cancer, diabetes, heart disease, the many conditions that you're addressing within your health centers. So as I've said it, if you really want to reach communities, the first point of contact, that patient navigator within those households, is going to be those mothers, those daughters, those folks who are tuned in and aware and are most cautious about the science and about the medical efficacy and safety of this drug. And we have to answer their questions first. So I think the survey reveals that, both the local and national surveys, and we'll have some challenges to address that. If we don't have the slides, I'll just move forward without the slides. So let's see if we can pull up the slides. Yes, okay. So just to cover some quick facts, the results based on a statewide survey of 1,180 residents of Massachusetts, including the following: 800 residents statewide, a base sample, and over samples of about 250 each of Black and Latino residents. I often joke that I've never had anyone call me to participate in the survey as a Black person. And most Black folks I know have never had a person call them to participate in the survey. So this one, we actually know that Black and brown folks participated in. It was conducted between November 18th to the 25th, a live telephone and online survey interviewing in English and Spanish. And the data was weighted first within race groupings by gender, age, education, and region, and then to known population parameters like gender, age, race, education level, and region for the state's population. This project was sponsored, as I said earlier, by the Museum of Science in partnership with the Massachusetts League of Community Health Centers. Next slide. Then just some top level findings from the poll that are important for our conversations tonight. The large majority say they plan to get the vaccine, but many are not eager to be first in line. Many who say they are less likely to take it mean that they want to wait for others to go first. There is a lack of a risk of inequities if the most willing go first. There are differences by race and socioeconomic status and who wants to take it earlier. The key hesitations are questions about whether the vaccine has been thoroughly tested and distrust in the government and healthcare issues. We know that there is growing distrust. Some of that is political division, some of that is Operation Warp Speed and the quickness upon which they developed this drug. And we'll talk a little bit about that with the scientists and the clinicians that are with us tonight. As you might imagine, there was a drop of 10% between whites and communities of color when it comes to getting vaccinated right away. So an important first step will be to have physicians reach out, as I said, to Black, brown, and immigrant patients to address their concerns. As you can see from the slide, 71% of people say they are likely or somewhat likely to take the vaccine. When you ask them a different way, when will you take the vaccine? 36% plan to take the vaccine right away, while 47% say they would wait until after either a few or many people have taken it, for a total of 83%. Again, this is encouraging news. We were seeing polls come out in August, September that were saying that half of Americans were not likely to take this vaccine because of all the concerns that we've talked about and we'll talk a little bit about tonight. We were also seeing polls that showed even a greater number of African-American and Latinx folks were not intending to take this vaccine when we know the disparate impact this is having with infections and mortality rates in communities of color. So this is encouraging, 83%, and the numbers bear out the same way for people of color across those indicators that they also are planning to take this vaccine, but want to wait and see others go first. Just 7% say they will never take the vaccine. That's the never vaccine folks, or the people who have a legitimate and sincere distrust in vaccines or in this particular vaccine. And we have to speak to all of those groups. Importantly, 38% of white residents say they will take the vaccine as soon as possible, compared to 28% of Black residents and 22% of Latinx residents. We really believe we have an incredible opportunity here to leverage the first phase of vaccine distribution among doctors and other healthcare workers to demonstrate to our patients that the vaccine is safe. So I want to go into our first speaker, and maybe before I introduce our first speaker, just on that last note, one of the key findings, and again, credit to the head of public affairs here at the Mass League, one of the key findings from that survey is who they trust. And it shouldn't be a surprise because we know when we have those illnesses I talked about, the diabetes, the heart disease, the HIV/AIDS, name the illness in our communities, we go in and we talk to our provider, our primary care provider, our ER doc, name the physician, and we trust them to give us the right guidance. The reality is here, the survey reveals that we trust our doctors, that a majority of those polled will defer to and trust their doctors, and we have to put them at the front of the messaging. That is many of you that are on this call. They will be watching what you say and what you do and leading them on this vaccine. In addition, we know community health centers and Museum of Science and hospitals and the American Medical Association. The chorus of all of us need to be lifting up the science and making sure that people understand this disease and this vaccine. So I want to go to our first two speakers. I want to introduce them and I want to get out of the way and let them do the presentation that we set up for tonight. The first is Paulette Chandler. Dr. Chandler is a primary care physician at Phyllis Gen Center for Primary Care, an assistant professor of medicine at Harvard Medical School, and an associate epidemiologist in the Division of Preventive Medicine at Brigham's and Women's Hospital. She is the hospital's lead for community engagement and education for COVID-19 vaccine trials. So I want to welcome Paulette Chandler, and she's joined tonight by Lindsey Baden. Dr. Baden is the director of the BWH and DFCI, the Dana-Farber Cancer Institute of Infectious Diseases, immunocompromised host inpatient and outpatient consultative services, and also serves as the division's director of clinical research. Dr. Baden's research interests focus on early stage vaccine development and the development of novel diagnostics and therapeutics, for fungal and virus diseases that affect transplant and cancer patients disproportionately. He is the program director for the Clinical Research Centers of Harvard Catalyst at Harvard Medical School and directs the Translational Accelerator Center for Clinical Investigation. That's a lot. So we're very fortunate to have two experts in the field. I'll start us off tonight, and I want to turn it over to Paulette and Lindsey.
So, Dr. Curry, thank you so much for such a terrific opening and framing. And I think the way you framed this resonates with so many of us. And I have been struck like you that we have 15 million persons across the nation who we know have been infected. And we have 300,000 that we know have died from COVID. And I think many of us back in January, February, March, April, as this pandemic pathogen emerged, realized the severity of the illness that it caused and the health consequences to our communities and the disproportionate health consequences to our underserved communities. And that has driven the research and innovation arena to figure out how to move faster. And the consequences were not just in the pure illness and death, but also in the disruption of society with closing of schools, businesses, of commerce, of our livelihoods. And on so many levels, society was turned upside down and we were unable to function and have all of the knock-on consequences of that. That has driven us to figure out how do we develop proper countermeasures. And a key countermeasure, a key way to prevent this are vaccines. And I would argue that vaccines, more than anything else over the last 100 years, that plus hand washing, probably have done the most to improve health and improve health for all of us. And what we see with these pathogens is we're all connected. A respiratory viral pathogen in one part of the world affects the rest of the world. One part of our community affects all of our community, and that we need to work together to stop transmission and the consequences of transmission. So one of the challenges with developing a vaccine, particularly one that is responsive to a pandemic, is making sure we do it safely and properly. And that has two key elements, safety and efficacy. And the efficacy that what we have seen last week with the review of the data from the Pfizer study and tomorrow with the review of the data from the Moderna study. And I should mention that I am one of the co-principal investigators of the NIH Moderna study. And so I'm heavily involved in that research and that work, both nationally and in our communities as well, trying to develop a vaccine rapidly. And what we see from both of those studies is 95% efficacy in preventing symptomatic COVID illness and an equal efficacy in preventing severe illness, meaning trouble breathing, hypoxemia, hospitalization, things that are associated with much more severe illness. So that is, to me, very attractive data that we can prevent significant medical illness with a vaccine. On the safety side, we have monitored safety and we have made these vaccines very quickly. And what one can see on this image, which is normally vaccines take about 15 years to make, 10 to 15 years. And that has many reasons. We understand the pathogen, we have to sequence it, we have to do a development on what we want to be in the vaccine, we have to do animal studies, we have to iterate on how to make the stuff. We have to do our phase 1 testing and review it, our phase 2 human testing, our phase 3 testing. We then decide if it works or not. If it works, we then say, how do we now manufacture it? And then how do we manufacture it to scale? Meaning, in this case, tens of millions, hundreds of millions, billions of doses. Next image. What this pandemic has pushed us to do is how do we do this from 10 to 15 years to 10 to 15 months and not short circuit safety? And we've not short circuited safety in that if we take risks on the manufacturing, meaning we invest in manufacturing while we are developing the clinical data, that saves many years. And if we plan the clinical studies so they're tightly linked, so there isn't a lot of time between phases. We choreograph them very tightly, and that way there is some financial risk because we're making investment to do studies for something that may not work, but it is not short-circuiting the safety. And these studies have been done with all of the phases, all of the safety assessments, with oversight from safety review teams to data safety monitoring boards, to the FDA review, to the CDC review, to the ACIP review, to the National Academy review. So lots of review of data to make sure that all of the elements are there to ensure safety and that the efficacy looks as strong as the initial signals were. So I think that what we have done in this unprecedented time over this last year is faced a horrible pathogen that is causing severe disease across all communities. We have responded scientifically by using our latest technologies, such as the mRNA technology, to rapidly make the vaccine, rapidly test it, and rapidly manufacture it to scale, to the point where this week, we have launched one of the vaccines, and hopefully next week, the second one will launch. And then we will need to determine how best to deploy this to our communities and how to allocate it. The initial allocations discussed by the groups that I mentioned, as well as the departments of public health, particularly the DPH of Massachusetts, of the Commonwealth, will determine the best allocation, but it will be focused on those at highest risk from work interactions, such as frontline healthcare workers broadly, and those at highest risk for severe illness, such as our seniors and those who are in senior care facilities, because that's where 40 to 50% of our deaths have occurred. And then rapidly extend it to all of our communities, because we have to stop transmission broadly, which means all of us get vaccinated. So that is a brief overview of what has occurred over this last year from the vaccine development. This image, a bit of how we've been able to accelerate the manufacturing with really financial risks, not safety risks or scientific risks. One of the issues in doing these studies, and I should say both the Pfizer study, which was 44,000 individuals, half get vaccine, half get placebo, and the Moderna study, which is 30,000 individuals, half get vaccine, half get placebo. So that's 30 to 40,000 individuals received these vaccines in the last 6 months. That those data have helped us understand how it works and the safety. And one of the things that's really important in these studies, which Paulette was central to, was engaging our communities to participate, so that the question is always, how do we know if this vaccine works in my community? And to do hard work to engage the different communities so they're represented in the to do there, but we have worked hard to try and engage broad communities who have been impacted by a social circumstance as well as medical susceptibility or illness, so that the samples in these studies represent our communities, and we have some data to understand the safety and efficacy in those who are older than 80, in our communities of color, in our communities with significant comorbid illness, such as diabetes, high blood pressure, obesity, conditions that increase the risk associated with COVID infection. And that has helped enhance our trust in the data because they represent the nation, the Commonwealth, and hopefully the Boston area reasonably, although not perfectly, because there are still many more questions to ask. But I think the initial data and the initial communities that have participated in these studies are encouraging that the results apply broadly to most, if not all of us. I don't know, Paulette, if you've made it through yet.
Doctor, just a quick question while we see if we can get Paulette on. I'm curious, you probably have seen, and I think many of the folks who work in our health centers are seeing, the misinformation about the vaccine. And there's a lot of work that we need to do to combat the misinformation. What are you saying, and what would you say to the staff, to your colleagues, the physicians at the health centers that are trying to combat the fake news about the vaccine?
No, I think, Dr. Curry, you're absolutely right. I think the misinformation and the distrust, what is challenging is there are legitimate reasons to be suspicious of things, to poke at things, to be convinced it's true. And so I think there are appropriate factual discussions we should be having. But that is very different than a lot of the discussion that's going on. In my view, a face mask, the one I wear when I go back on the wards later tonight, is not a political issue. It is a matter of how do I protect myself and those around me and protect you, because I don't know if I have COVID. And I think that we need to deal with misinformation and disinformation because that is so corrosive. And I think these vaccines, we always need to learn more, but there's a difference between learning more because we want to understand finer tuned details versus the current tsunami of illness and death that is occurring every day, and with 2,000 to 3,000 deaths per day, including many in our communities. That is an incredibly serious problem, and we must be transparent, communicate with each other, share what we know and what we don't know, but let the science lead us to better health. And I think that this group and our community health centers, and looking at the earlier poll and seeing the representation of team members being all of the team members in our community health centers, are the exact people that have to be part of this discussion so that they're more comfortable with the data and the efficacy and the safety, which, you know, I always want to learn more. I'm always concerned about knowing more, but these vaccines with 95% efficacy are incredibly, they exceed all of our expectations of efficacy. Problem that is front and center every day. So I agree, Dr. Curry, that this is a critical issue of elevating the discussion and having the dialogue so people can get their questions answered, and hopefully we can rely on the science and let that guide us to how best to deploy what I think is a very effective medical intervention.
Thank you, Dr. Baden. I am going to, Mahalia Curry would be smiling right now. She knew you called me Dr. Curry. I'm an attorney. I went to that in that other line, but I appreciate the work that you do. We'd be remiss if I didn't say this. My son came into my room around the height of the pandemic, early in the spring, with the picture of all the superheroes lining the hallway and the clinicians walking down the hallway, and they're all bowing and applauding the clinicians. And I think that really sets this conversation as well, that many of our community health center providers and staff, quite frankly, risk their lives in this moment, like the hospital clinicians and staff. And I just want to recognize and applaud the work that you do to bring care to the communities that we all care about. So again, thank you, Dr. Baden, for that. We're going to come back to Dr. Chandler when we get her audio fixed and we can get her back. I want to go to Dr. Bisola Ojikutu, who is an assistant professor of medicine and global and social medicine at Harvard Medical School, an associate physician with the Division of Global Health Equity at Brigham and Women's Hospital. She is also a faculty member within the infectious disease divisions of Brigham and Women's and Mass General Hospitals. Recently, she has focused her efforts on increasing the participation of racially and ethnically diverse populations in COVID-19 research and promoting vaccine uptake. She is currently funded through a collaborative partnership with RAND Corporation, dedicated to developing strategies to address COVID-19 vaccine hesitancy within the Black community in the US. So we have a reaction panel starting with Dr. Ojikutu. So I want to start with you, Doctor.
Thank you, Michael. Can everyone hear me?
Yes.
Great. So I really am honored to be here to speak with you this evening. As Michael said, I am an infectious disease physician. I'm also a health equity researcher, and a lot of the work that I do is focused in on mistrust across many different biomedical interventions, and particularly within Black and Latinx communities. You know, I think the data that Michael presented is quite encouraging, and I'm very happy to hear that so many people are willing, or at least maybe not now, but they have sort of a wait and see approach to taking the vaccine. But I would caution us not to be too comfortable with that information. Okay, I really want us to continue to be aggressively thinking about how to address hesitancy, because we are going to see disparities in access. We are going to see disparities in willingness to take the vaccine. There are going to be populations who are going to be more difficult to convince, and these may be our highest risk individuals. You know, we've seen a lot of disproportionate and stark disparities in regards to uptake of our routine vaccines. Many of you all are clinicians, you know, working in the community health centers. You probably saw it in this last flu season. And if you look at the CDC data from the 2019 to 2020 influenza season, less than 50% of all individuals actually, you know, took the vaccine. Now, whether that has to do with whether or not they were offered it or they refused it, you know, it doesn't really come up in that particular data set. And then when you look at that by race and ethnicity, you certainly see disparities where Black individuals, Latinx, and Indigenous populations actually only, you know, receive the vaccine about 40%. So 40% of those populations versus the overall sort of 50% and more in white populations. And I think that if you look at our other routine vaccinations, pneumococcal vaccine, HPV, certainly herpes zoster, we see these gross disparities. So I just want us to remember that these issues didn't arise with COVID, they've been amplified with COVID, and we are going to see some issues that we're going to need to address. So then how do we do that? How do we prepare ourselves? So I think first and foremost, you know, we need to keep in mind that we need a multi-level coordinated approach. And I think one of the first steps in that multi-level coordinated approach is having appropriate messaging. And you know, there have been some large efforts that have been funded to really look at messaging, and some of the work that we're doing now with the collaboration that was mentioned is to kind of look at what messages work best with what populations. Because I think you have to be appropriate and realize that people are very diverse in their belief systems. So I'm just going to mention a few of the messages that we're sort of looking at and things that you could probably easily incorporate as you start to think about how to encourage people to think about these vaccines and to consider them, because this really is about choice. First, acknowledging the mistrust, acknowledging that structural racism exists up front, and that it, like Lindsey said, like Dr. Baden said, you know, it's normal to mistrust the institutions that have been so abusive to many different populations in this country. So it's showing your empathy and understanding and understanding that people do want you to know, and people want to feel as though their providers understand that structural racism does exist. Another strategy that has been used and has been found to be helpful is framing vaccination as empowerment. If you are vaccinated, that's a way to fight back against the structural racism, the systematic inequity that has led to these gross disparities. So that's another way that people have sort of looked at how to encourage vaccination. Being transparent. You know, we have some data at this point actually explaining to people exactly what the side effects are, you know, being very clear about those side effects, and also telling them what's unknown thus far, because there are many unknowns. You're being very clear about what we know and what we don't know. I think another piece that's been brought up in many different discussions regarding biomedical interventions is the fact that if you look at the data, oftentimes Black and Latinx and other populations within our country don't trust specific entities, right? So the pharmaceutical industry, one, you know, just feeling as though the pharmaceutical industry is very profit motivated, and there's sort of a lack of trust in their motivations. And yet in our media, we've sort of been inundated with this feeling that this is a race. You know, okay, so there's the race and Pfizer won and Moderna's next, and then there's AstraZeneca. And a lot of that has actually bred some deep-seated sort of mistrust within the industry. And that's not to say that there's anything wrong with pharmaceutical industry. Some of my good friends are you know, within the pharmaceutical industry. But what I would say though, is that pivoting away from that messaging in regards to how we communicate the issues related to vaccination is going to be very important. And lastly, I'll just wrap it up by saying that you know, vaccine hesitancy is a real issue within our own healthcare providers, within our colleagues. And before we can be influential and help our patients to make the decision to take the vaccine, I think we have to deal with it within ourselves, and we have to understand what our hesitancy is and think about how we can educate ourselves and build confidence around these really important and efficacious tools, so that we can then encourage our patients to also take the vaccine. So I'll stop there.
Thank you, Doctor. And there's many things in what you said that I hope folks took some note of. One thing I want to just lift up that I thought, and I would totally agree with you, acknowledging structural racism exists. It's one of the questions I would have asked later on in the program, but you attacked it head on. So I wanted to lift that up. We talk about Dr. Marion Sims' experimentation on slaves, Tuskegee syphilis experiment, those 40 years or so of experimentation on Black men, Institute of Medicine, unequal treatment. So there's a lot of data around the unequal treatment, but I think we want to make sure that we address that in a direct conversation with people. I want to go back to Dr. Chandler. I know you're back with us, Dr. Chandler, and give you an opportunity.
Sure.
As well.
Great. So Bisola said a lot of what I was going to cover in terms of addressing people's hesitancy around vaccines related to, one, they feel like they're exploited. Two, they're concerned about the safety of the vaccine from the perspective of the rapid development. Three, some have religious perspectives that they don't want to engage with a vaccine in the sense of they think, oh, well, that would deny my belief in my power of my God. Others have natural remedies that they want to use, and they say that vaccine is artificial. I don't want anything artificial. And then, of course, the underlying racism, the day-to-day racism that people are experiencing, it's important for clinicians to acknowledge that because that shapes how they interact with the healthcare system. Also, the mistreatment that individuals, communities of color, Black and brown folks have experienced in the healthcare system shapes how they're receiving the messaging about the importance of the vaccine. Not to mention the societal injustices that people experience day by day, and they witness others experiencing, from the police brutality to unfair sentencing to mass incarceration. So I think as we push out the vaccine and emphasize the importance, we also need to parallel that with the importance on addressing racism and how racism makes us sick too. And we have to address the systemic inequities that are generated by racism. So people are pushing back when we say, oh, you have to be vaccinated. They say, well, what are you doing about this racism that's influencing my access to adequate housing, my access to educational experiences, my access to fair wages? And then, and of course, those are thoughtful conversations that we have with our patients and with our community leaders, and also allowing our community leaders to share their experiences about what are effective solutions and strategies for addressing this systemic racism that has really been exposed through this pandemic.
Thank you, Dr. Chandler, and I'm glad your input is vital to this conversation, so I'm glad we got the audio fixed. We'll have some questions on the end, so I'll open it up for our panelists to weigh in on. I want to go to Julie Levinson next. Dr. Levinson is the Assistant Professor of Medicine at Harvard Medical School and is co-director of the Community Research Program at Mass General Hospital Chelsea Healthcare Center, where she is also a practicing infectious disease physician specialist. Julie, so you are our second reaction panelist.
I want to thank you, Mr. Curry, for having us, and I'm so honored to be with these panelists, my colleagues, and all of you, and I look forward to hearing the questions and learning from them. Apologize for the connection there. My reflections will be in part as a clinician working in a multicultural setting in Chelsea, where at least half of our patients are non-US born. And I'll also briefly reflect on our experiences from our research team working with HIV patients who are Latinos, many immigrants, as well as managing the emerging infectious disease outbreak of Zika in Puerto Rico. So, I think there's some common themes that have come up. One, I think one of the strengths, and Michael has been saying this, all of us have been saying this, we're in a unique position in a community health center to be on the front line and be seeing people over the lifespan. And that really gives us an opportunity to broker these hard conversations that require trust. So one of the things that really comes up, and I'm sure the participants would echo this, is the really dire experiences around social determinants of health. So patients come to us maybe with a clinical concern, and we learn about really significant issues around food security, about inability to pay the rent, tremendous suffering with physical separation from family, who may be in another part of the US or in another country. And so attending to the vaccine and COVID-19 vaccine is within the context of also addressing issues that may be just as important, if not more important, in the eyes of the patient. So part of the clinical encounter, I think, is stepping out from what we think is important and really trying to assess what's important to the patient. And I know we do that all the time, but it's trying to be receptive to their concerns. So one of the things we found effective is trying to bundle these interventions of vaccination with things that really appear in the forefront of our patients' minds, like food, housing. And I think with that, I'll say just how key our peer staff and community health workers are in bolstering these conversations, serving as trusted messengers of vetted scientific information, but bringing it down, even if we think we gave our best effort, that they can sometimes communicate it in a way that we try, but didn't quite cross the finish line, but we can do it together as a interdisciplinary team. So I can't say enough and lift up the voices of our community health worker staff, our peers, our nurses, our social workers. Sometimes it's just communicating, but also having an extra hand on site to do more listening, to building the trust, and also trying to address misconceptions. And then lastly, I would say, again, as Dr. Ojikutu and Dr. Chandler and Dr. Baden talked about, communicating and setting expectations. We know the virus, at least the vaccine data early shows decreasing COVID disease, decreased severity, but we still need to understand about transmission in the population. So that means there are areas that we don't have complete information, and we still need to encourage things that we know work, like masking, hand washing, physical distance. So I think the more that we can be transparent about what we know and what we don't know helps us build trust as we walk with them in some of this uncertainty. And I'll pause there and thank you again for the opportunity.
Thank you, Dr. Levinson. We're going to go next to Dr. Zingodita. It's Juan Jaime de Zingodita, is the medical director of the Southern Jamaica Plain Health Center, an instructor at Harvard Medical School, and a primary care doctor. He is also part of the regional leadership at the Primary Care Center of Excellence at Brigham's and Women's Hospital. He has helped lead the racial equity work at Southern Jamaica Plain and at the hospital, and has participated in LGBTQ patient and staff advocacy as well. We are honored to have you here, Dr. Zingodita, and I'll turn it over to you next for a response.
Thank you. I was asked to talk about sort of the experience of healthcare at the health center for us over the past 9 months. I'll say that obviously I'll emphasize what's been said already. It's been a terrifying time for people at the health center, often because of the uncertainty from the beginning of a new disease and the reality of having to be present in a place where things like how is it transmitted and how dangerous it will be were unknown. Granted, as the time has gone on and we have better understanding, what's replaced sort of fear of the unknown is just the fatigue of the change that we've had to endure, the new workflows, and frankly, implementing an entirely new modality of healthcare to virtual care. In addition, we've, as what Julie has just said, we had to take on the role of addressing the social determinants of health. We've calculated we've given out tens of thousands of pounds of food in the past few months. We've helped hundreds, if not more, people avoid eviction and are now scrambling to respond to that as well. And now comes the vaccine. We've been dealing with vaccine hesitancy for years now. We've talked about the reasons why that is. That has to do with personal experience with the structural racism in healthcare, distrust due to the lived experience of people. We have to come and begin conversations with people, which often means sort of challenging their lived experience. Like very often I tell people they need the flu vaccine and they say, well, it makes me sick. and how, that's something that it's their reality. And the first thing that I have to do is sort of say, yes, that probably happened, but let me tell you why it might not have been from the vaccine. And then going back to the staff, this is often the staff in our community overlap. So while people obviously have to get vaccines to work here often, like the flu vaccine is required, at least where I am, it's still, we're dealing with a new and untested in their minds vaccines. So in our own health center, we did a similar poll to what we just did here at our last staff meeting, and 2/3 of people said no or maybe to taking the vaccine, and that was a few weeks ago before the current trial results were made public. So we definitely understand that within our own ranks, we have to address people's concerns, and that begins with sharing information, being transparent, as people have said, about what we know and don't know, and being available to listen to the questions that they have, which we plan to do in a follow-up meeting as well. So just to summarize, I think healthcare workers at community health centers have been through an extraordinary year. They've put in 110%, and now we have to gear up for yet another effort, which is going to involve all our attention and all our efforts. And things like the forum today are going to be crucial in getting people ready. It's hard to convince people to do things that you don't yourself believe. So I think that this kind of discussion within the places of work these are going to be crucial to our success. That's sort of the end of my comments.
Thank you, Doctor. And of the many points that you raised, I want to just touch on one, which is I worked on the COVID-19 vaccine working group, the governor's working group. And the point you just made was a critical part of that. The reason we do healthcare workers first is because we need healthcare workers on the front lines to respond to this pandemic, which we will be dealing with for the foreseeable future. In addition, it was understood by every member of that working group that if doctors and nurses and our healthcare workers broadly are taking the vaccine, then they can deliver that message to patients. So I just wanted you to know that that was a key part in the prioritization by the CDC and a key part by the state prioritization as well. So thank you for that. I want to go to Adriana Bolin. Adriana is the Community Outreach and Engagement Manager at the Fenway Institute. Her focus is on health and racial equity as a pathway to justice by identifying and initiating systemic and structural change needed to prevent inequitable health outcomes. Currently, she is focused on engaging community and clinical research as the lead of the community engagement and biomedical research recruitment at the Fenway Institute and director of the Boston Harvard Providence Clinical Trial Unit Community Engagement Course. So I want to turn it over to you next, Adriana.
Thank you, Michael. And it's an honor to be here with you all. We've had a lot of great conversations and I'm happy to be a part of this. I want to explore with you for a moment community engagement and how we can connect and collaborate with our communities more intentionally. We've talked a lot about it. And before we dig into it, I want to first differentiate community outreach and community engagement. In a recently published article discussing how we can authentically invest in community that was actually authored by doctors Bisola, Ojikutu, Catherine Stevenson, Ken Mayer, and Karen Emmons, community outreach is defined as temporary, unidirectional, and focused on limited goals. By contrast, community engagement is a longer-term process of working collaboratively with groups of people to address issues affecting the well-being of those people. And when I say intentional engagement here, I mean engaging people in ways that will best serve them and in turn serve and progress our collective goals. And our collective goal right now is to end the pandemic. We want to hug each other, we want to embrace each other, we want to be able to be out there in the ways that we did before. That's our collective goal. And so in three, the way we get there may be different, but we have that same goal. And so 3 grounding questions that I want to offer for you all today when you're engaging with people around vaccines is what motivates that person in general? What empowers that person and what makes them feel a part of something? We're in a time in the world right now. We mentioned distrust, we mentioned other misinformation. What I wanted to add to that actually is misinformation and distrust. I actually recommend to validate that energy. The energy that's coming behind that person's personal truth is energy of them caring about their health and wanting to define what it means for them. So actually, I like that energy, and I want to equip that energy with the tools and information needed to make the right choices for them. You all in this field have the opportunity to engage in ways where the community will actually feel a part of something. There are a lot of experiences that people in this world have that make them feel not a part of something, not respected about something. And so you have the opportunity in your hands to show them that they are a part of this collective effort to end the pandemic. And so with these tools, this knowledge that we've shared today, that you've read, that you have in your experiences, you have the power to navigate and facilitate interactions that inspire healing and positive, sustainable change in our community. Thank you.
Thank you, Adriana. I am going to close out the reactionary part of this with Mike Kincaid. And I want to thank you for your comments earlier, Mr. Kincaid. Mr. Kincaid serves the chair of health services at the Dimick Center's board of directors. In addition to his volunteer service, Mike's career in health education and community outreach is focused on youth services, HIV/AIDS, community development, and Alzheimer's disease. So I want to turn it over to you last, Mike, for reaction.
Thank you. I've been asked to talk about partnering with community stakeholders. And before I do so, I want to thank Julie for giving a shout out to community health workers, because as someone who's also a certified community health worker, they're on the front line. They're the boots on the ground. They're the ones that are out there getting to know the health center clients in their environment. And you know, the amazing thing about community health centers is they really don't believe that if you build it, they will come. They engage the community. They go where they're at, and they provide them with comfort in their own backyard, so to speak. But the thing that I want to talk about community engagement, and Adriana, you hit it right on the head with the difference between outreach and engagement perfectly. So I would challenge community health centers to think outside the health center box and community stakeholders. I was sitting here jotting down on just some of the organizations that we at the Dimick Center are reaching out to. Right off the bat, we're reaching out to our local cable access station to provide real, and when I say real, I mean, you know, I don't want to use the word honest, but I want to say correct information that the clients are asking them, and being able to answer those questions. Reaching out to other groups, you know, I've got down here local professional groups, and the first two that come to my mind is the NAACP and the Urban League, senior centers and youth centers, places where, although people are not gathering right now, they're still doing virtual things. And they have clients that are looking for this information, and they don't know where to go. And so it's things like utilizing these type of relationships. And last but not least, lean on your board of directors. The members of my board, we just had our meeting this Tuesday, and you know, I love the fact that I talk with a lot of them privately, but I'm encouraging them to help us get this message out there. So I'm going to stop right there and just simply say that we in the community health center world have to think outside the box. We've got to get outside the the medical community and go where people are and meet them where they are and understand their concerns.
Thank you, Mr. Kincaid. I'm going to, with the time we have left, and we've had over 500 people on the call tonight, so I think that's huge. I want to lift up what was said earlier, that the education starts with us. As we start to figure out a strategy to reach out into the community, we have to make sure we're on the same page about the science. As Dr. Lindsey said, Dr. Baden said, that the efficacy, the safety, So that's the importance of this conversation tonight. I want to jump right into some questions, and I'm going to go back to you, Dr. Chandler and Dr. Baden, with some medical questions that have come up pretty consistently. The first question is, what are the known or anticipated side effects, reactions for the vaccines? How long do they typically last? And are there any permanent side effects, hospitalizations, or deaths? That's the question, but I want to tee it up a little bit more with this. We know that the flu vaccine has a reaction, as was said earlier, in some patients. How do we deal with the heightened awareness that people are going to have every time they hear of a reaction to a COVID-19 vaccine? So just I'll turn that over to Dr. Baden and Dr. Chandler to weigh in. We'll start with you, Dr. Baden.
Thank you, Mr. Curry. The issue of side effects is, and I think about this with penicillin. Penicillin has side effects. Yet if I had pneumonia, I would take penicillin. If I had an infection, I would take penicillin. So the side effects are very rare. What we can say with vaccines, the side effects are even rarer, much rarer than even with penicillin. And the kinds of side effects that we see with the flu vaccine, where my arm may hurt for a day, is much less severe than flu in most people who get the flu. The shingles vaccine has side effects for a day, and it prevents shingles or zoster. The COVID vaccines, the side effects that we've seen in 20, 30, 40,000 individuals vaccinated is that in some of them, maybe 10 or 20%, particularly after the second vaccination, they may feel bad for a day with some fatigue or malaise, and it goes away. No sequelae, no hospitalizations, no more serious side effects. So we need to be cautious. We need to be open-minded that we will learn more as millions and tens of millions receive it. But in tens of thousands of individuals, the side effects have largely been, I don't feel good for a day, and that goes away without any sequelae, any problems. It comes, it goes, and only in a small number of individuals. And that, in my mind, compared to 2,000 to 3,000 deaths a day, is a very favorable risk-benefit ratio.
And Dr. Chandler, I know you may want to weigh in on that, but I'm going to add something to your question as well, so we can get through as many of these questions coming from employees at the health center as possible. I'm going to add to yours. How long will it take to build immunity after getting the COVID-19 vaccine? Folks are listening to CNN and MSNBC, and they're hearing this 80%, 75%. Can you speak to those things as well?
So the immunity to the vaccine, what we do see is from illness is upwards of 95% of people are protected from illness after 2 immunizations or after about a month. What we do see is an immune response emerging after about 2 weeks. So there's evidence of immune response after about 2 weeks. It is boosted or made stronger by the second immunization. And then we are currently studying how long it lasts. We know out to 3, 4, 5 months it lasts. It should last a whole lot longer, but we'll only know that a year or two from now when we can follow people who've been vaccinated long enough. But the immunity emerges within weeks of being vaccinated.
And I want to ask an open question, and maybe Dr. Ojikutu and others. How do we, and Dr. Baden spoke to this, but I want to give others an opportunity. Our biggest challenge is going to be the misinformation. What are some strategies to deal with the misinformation about this vaccine? What do you think we should be preparing for to do that?
So I think that's a great question. I think there is quite a bit of misinformation out there that we're already dealing with. I mean, that's part of the, sort of issue we're discussing in terms of mistrust. And I think a number of strategies have already been described, but let me just maybe put it into a framework. Most of us have been taught patient-centered communication, right? So patient-centered communication, we focus on the patient's needs, we focus in on the patient's perspective. I think the same thing applies to these issues of misinformation, to conspiracy theories, if you want to call them that, to any hesitancy that they have. we listen to patients. We listen, we understand kind of where they're coming from. We try to convey that sense that we understand where they're coming from. And we try to resist the urge to jump in immediately to like write them, to tell them they're wrong about whatever they're saying. Listen, because there's a reason that people mistrust. There's a reason why people believe in conspiracy theories. Hear what they're saying. You'll learn something from it. Then take a step back and provide them with the accurate information. And like I think Julie said already, you know, we need to be very clear about the fact that we know some things, but then there's some things we don't know. And then continue to build a trusting relationship, which many of you already have with your patients. So I don't think there's a huge science to it. I think we have the tools already. We just have to continually be implementing them.
Thank you, Doctor. Julie, I'd love to have you weigh in on some of these questions that are across the board about who should be safe to take the vaccine. You know, people are asking about children, should kids take the vaccine? Should pregnant women take the vaccine? There's a lot of conversation going on and people are trying to find the answer in different sources. Any information you can provide on where we are with who's able to avail themselves of this vaccine now and hopefully into the future?
Those are excellent questions. And I know, Lindsey, for example, there's been a lot of discussion at the level of the Infectious Disease Society of America about, for example, pregnant women and thinking about potential immunologic effects. But Lindsey, do you want to comment on that specifically? Whether pregnant women should be vaccinated?
I think Julie, as you know, of all the groups, the pregnant woman is the most complicated, because how do we manage with the uncertainties around the pregnancy and the growing child? So I think that's very complicated. Theoretically, there shouldn't be an issue because the vaccine's given in the arm and it stays in the arm and the regional lymph node and is gone. And what it doesn't get into the DNA, doesn't get into the nucleus, it doesn't do anything that raises any concern. It is local and it then stimulates the immune system to develop the immune response. And in some ways, that immune response can be passively transferred to the baby and afford some protection, as we know for other infections that mother to baby transfer of antibody is very protective. So there's a lot we don't know. Theoretically, there should not be a concern, but practically, we are all just cautious to do things very carefully and stepwise.
And I want to jump over to Adriana real quick around community engagement. Give us an idea of what it looks like. You know, I've been a part of so many task forces. Right now, I'm a part of way too many task forces and work groups. But everyone's talking about community engagement. You've done this work. What does it look like, and how is it effectively done as we as health centers begin to plan our work?
Thank you, Michael. What it looks like is listening, and starting with listening and understanding that not one lone framework is going to work for everyone, but it starts with listening. And I like to also pose the grounding question, you know, who are you engaging with and why are you engaging with them? And really thinking intentionally and thoughtfully about that. Who are you engaging with and why are you engaging with them? And it has to align with what motivates them, what empowers them, and what their greatest needs are in that moment. We want to engage them and encourage them to take a vaccine while they may have other things going on in life. And we need to understand how that may connect to how we're engaging them and tailor the way that we engage them in that way. Something that I like to bring up often is the stages of change, or the trans theoretical model, for those of you that might be familiar with it. And when you think about, someone can be at a different point in that model at any point where you're seeking to engage them. And it takes approaching them with the right tool in the right way for it to be effective. Someone who's in that pre-contemplation phase, who's not really trying to hear it and isn't thinking about a behavior change, doesn't want to do a vaccine, you may not reach them on social media, may not reach them in person, then, but if you have a paper, a flyer, information about a vaccine that you provide for them, they may leave that on the kitchen table. They may walk by it tomorrow. They may start contemplating. They may start planning. They may be motivated for action. Maybe if you give a follow-up call and remind them that vaccines are happening, maybe they'll be more apt to do it. So it's really listening and observing where someone is at to identify how to reach them.
Excellent. I want to go back to Dr. Chandler. Paulette, can we get you on?
Michael, can you be a little louder, please?
Yes, absolutely. Paulette, are you back on? We can't hear you. I think it's just your phone. If we can hear you, I'd love to ask a question.
How about now?
Okay, perfect.
Perfect.
Here's a question that we got as well. Is it RNA based? Does it change the genetic structure in any way? The mRNA science is new and makes me nervous. Shouldn't we wait until the other vaccines get approved? And can the mRNA change the DNA of a person?
It is messenger RNA. It does not change the DNA of a person. I mean, I get these emails all the time. As Lindsey mentioned, you inject it in the muscle, it stays in the muscle tissue. It does enter the cell. And of course, as messenger RNA, the cellular machinery reads that messenger RNA and it produces a protein. And then that protein is what, stimulates the immune system to make the antibodies against the virus, specifically against the the spike protein on the virus. So no, it doesn't alter DNA.
Thank you.
And that's the key question that people have been expressing fear about, altering of the DNA.
It is probably the one I see most online, as people have been sending me clips of physicians arguing that it changes your DNA. So we really need to combat that false science. Mike, I want to go back to you for a second. You talked about the work that you and others do, and particularly around community health workers. We know that the Mass League and many of our members want to equip community health workers with what they need to go out in the communities, both to share the information and encourage folks to take the vaccine. What's your thinking around strategies to do that work? How do we now employ much of what we heard on the call tonight to then have our ambassadors, which are our community health workers, go out and share that message?
Well, that's a tricky question, because one of the things, and I can't speak on behalf of all community health workers, but one of the things when I begin a relationship with a family or an individual, and I believe Adriana also mentioned this, it's almost like we're saying the same thing. I meet them where they're at. I'm not surprised by the data of people who are not, who say they're not going to take the vaccine. What I am surprised is that there's not much follow-up on why not. And where I'm going with this is, when I say you got to meet people where they're at, I work in the world of Alzheimer's research, and it's amazing how many Black and brown folks are not concerned about getting engaged in research. And the reason that I hear so many times is because it's not a high priority for them. So when it comes to arming our community health workers with what they need to engage the community, and as crazy as it's going to sound, is I keep saying we've got to think outside the medical box. Those of us who worked in the field of social work know that before you can work with a family on what you want to work with them, you have to make sure they have all they need. So that's what I would say for the community health workers, is arm them with what they're going to be able to provide with the community. A lot of community health centers like the Dimick Center are providing free meals. The PPE, they're providing things that folks need so that they can build that relationship, so that when they ask them for, can you come in and do the vaccine, they're not inclined, I think, to hear no because they built that relationship.
Thank you.
Mr. Curry, can I just follow up on Mr. Kincaid's point? I also wanted to just talk about the importance of protecting our community health workers, meaning not only the point about having them have adequate personal protection, gloves, masks, so forth, but also attending to the mental health consequences of being on the front line and walking with people so intimately in the lived experience can have a trauma with that and need attention to depression, anxiety, the multitude of mental health issues that come up, and also sometimes reliving their own life experiences. So I can't emphasize enough the importance of how wonderful our mental health team has been, not only in caring for the medical staff, but also caring for the community health workers and having those regular check-ins to hearing how they're doing. I think we need that for the sustainability.
Thank you. I'm seeing some common themes come through, so I'll open this one up to anyone who wants to address this one. I've heard that even if I am vaccinated, I can still transmit COVID to someone, even if it is on my gloves or surface. Is that true?
I think that the issue of transmitting COVID, there are two parts to that. One is, can I amplify it? By getting infected, I make more COVID, I shed more COVID in the environment. And that's why I wear a mask to protect you in case I have it. The next question is, once it's in the environment, how long does it last and how easily can I spread it? And that's where we still need to make sure that we sort of do our routine protective mechanisms that we've talked about. But I think that once a lot of us are vaccinated, the amount of virus around us will decrease substantially. But right now, there's just too much virus around us that we still have to be just as careful as we have been. But the hope is by being vaccinated, that will make you less likely to be able to carry the virus even transiently.
And Dr. Baden, while we're with you, maybe another follow-up question. There's some common themes both in this conversation tonight and I'm hearing in other settings, which is if you get one vaccination, Pfizer, but then you get Moderna, and the timeline, if you fall outside of the 21 days for Pfizer and the 28 days for the second vaccine for Moderna, and whatever the other vaccines will eventually be, if they're 2-dose, how does that impact the protection that you get from the vaccine?
So as we said before, there are many more questions than answers. What we know is that the 2 doses of Pfizer 21 days apart and the 2 doses of Moderna 28 days apart have the 95% efficacy, very high efficacy. Once we change that and it's a single dose, or it's a single dose spread out over 4 months, or we're mixing the 2 different vaccines, we don't know. My guess is probably the second immunization will help no matter when or what the first one is, but we don't know because that's not been studied. At this point, what's been studied has been very focused, as I mentioned.
Excellent. And I'm going to do a little audible here and allow for folks, I know we have quite a few more questions. I try to get them in themes, but I want to go back to folks and starting with Juan. Just your thoughts, some things that you think we've talked about tonight that we haven't covered that you wanted to add.
Well, I mean, I think a lot of the work, a lot of discussion has been about how we convince patients. And I think I want to emphasize again that we have to be ready ourselves. And that means working with our own staff in terms of understanding what their concerns are and I mean, applying the same techniques and approaches. But I think, like I said, our experience at our own health center was that there's a lot of work to be done first before we can actually engage in this. And as much as all of us are here to take care of our patients, and particularly in the past 2 weeks, we've seen the ravages of COVID. We want to make sure that people are prepared to do what we need to do to make this vaccination campaign a success.
Thank you. And Dr. Chandler, anything that is critical for us with the time we have left that you want to make sure people understand as they gear up to distribute this vaccine in our communities?
Right. Just the other aspect of not only thinking about the mental health challenges for the people that are delivering this information, but also about the attacks that people may receive when they encourage people to get the vaccine, because that's another aspect that people have to be strengthened and encouraged to brace, that they will undergo attack from those individuals that do not want to have this vaccine promoted in their communities.
Thank you. And Dr. Ojikutu?
I feel as though we've covered a lot in this time frame, and I guess one thing that I would say is really that I think that the data that you presented in terms of willingness to take the vaccine is actually hopeful, and that we should walk away feeling hopeful. But I would say that we are going to have issues. This is not going to be a smooth process. So we have to kind of be prepared and think to ourselves what it is that we're going to say to patients, and realize that for many patients, this is not on the top of their list of hierarchies. This getting a vaccine for COVID it's not the main issue that they have. They have many other issues, and we're very used to dealing with patients with lots of complexities, whether they be social determinants like Julie spoke about, or other medical issues. So realizing that this is going to be a process, it's not going to be one conversation with people. This is going to be many conversations, and we have to be in this for the long haul.
And I want to go back to Dr. Ojikutu for a follow-up question. One of the things I thought was interesting, and it's not often talked about in the survey, was the numbers of people, particularly some significant percentage of the African-American population, and then by party, Republicans, who believe that COVID-19 isn't real. So if you don't believe the disease is real, then you're not going to trust the vaccine. Would love to hear your thoughts on folks who still distrust that we're in the middle of a pandemic. Right.
I think that's an important point. There's a wide array of beliefs here. There's a spectrum. There are going to be some people, a proportion, a smaller proportion, who are just never going to get there. They're never going to believe that this was real. They're going to believe this was a conspiracy, and they're never going to take a vaccine. And the reality is that that's okay. We have to focus in on those people who are hesitant, who are on the fence, or who have that sort of wait and see approach, particularly during this period of emergency use authorization, where there are a lot of people who are saying, I'm not going to take it until it's fully licensed. So we have to kind of assess our patients, the time that we have available, assess where they are in their thinking process, where they are in their willingness to take the vaccine, and then work on those who have questions, work on those who may have beliefs that we think we can alter. There are going to be people who will never really get there. And I think that at the end of the day, that's probably okay in terms of herd immunity.
Thank you. Dr. Levison, I want to go back to you. Just your thoughts, anything that we think that the health center folks that are on the call tonight need to hear, be thinking about, or planning?
Thank you. I want to underscore the need for the multidisciplinary approach, not only the community health worker peer approach, but also the multi-specialty approach. Because as we are having our bi-directional communication with patients, we're going to learn things that may surprise us, that may not surprise us, but we're going to learn hopefully new information, and that's going to need colleagues to come in and help us answer the needs of patients. And so one of the things that we found successful at the health center, we're having screening tools that not only included the COVID clinical symptoms, but also, again, social determinants of health. And I can't underscore that enough in terms of being able to bundle our response to patients in a holistic way as much as we can include our multi-specialty colleagues.
Thank you, Doctor. And Adriana, I know there's a lot, and I'm most concerned as we get ready to turn this conversation from an internal conversation to an external conversation. Any last reflections on what we need to be thinking about preparing?
Absolutely. Lastly, just to say that you all have the power, the agency to create change. And part of your role in that is to to show your patients, show everyone in the community that you work with that they too have the power and agency to change and influence their health in a really, really positive way. So I encourage you to take the tools you heard tonight, continue to build on that, share best practice with each other so that we can encourage people to influence their health in those ways. Thank you.
Thank you, Adriana. And Mike, going back to you, and Mr. Kincaid, any final thoughts as well?
My final thought is, I've been thinking about this, you know, there's the analogy of the babies in the river. I have been dealing with misinformation and distrust in the medical community for over 20 years, and I've been dealing with that. So I just wanted to say to folks that when you find yourself in that situation, instead of grabbing the babies out of the river, go upriver and find out who's putting them in there. And what I mean by that is find out where that mistrust comes from. Find out, you know, everybody's an expert on themselves. So find out, you know, where did they learn what they thought, what they think, because that's where you start to dismantle it. And that's what I want to share with folks is if you're just snatching the babies out of the water right then and there, you're not really addressing the root core of what started it. That's all.
Thank you, Mr. Kincaid. There's a slide I want to show before we close out, but I'll make a closing comment. Information is the key. There's a lot of resources, both the CDC's website, the Mass Department of Public Health website. We need to utilize all those resources and answer those questions. One of the primary questions we're all going to get is, what is the prioritization? What are the equity concerns that are existing with COVID-19? We have to be able to answer those questions really without much thought, and that requires some research. So I want to encourage people to go to the state's website and take a look at the prioritization for vaccines, starting with healthcare workers, long-term care facilities, congregate care facilities, home healthcare workers, the first responders, and the others. And that includes, and this is probably an interesting point, that includes those who are homeless and in homeless shelters, as well as those who are incarcerated. That is different from many other states. And I want to lift that up. That's different from many other states. Our policy here in Massachusetts, I say, reflects our values. And thankfully, there were folks at the table advocating that we include vulnerable populations that are at greater risk in those institutions and facilities. So I just wanted to lift that up. Last but not least, the League Vaccine Preparedness Initiative. You see the slide here, COVID vaccine email for health center questions. Please utilize these resources. You'll see COVID Vax at massleague.org, the COVID vaccine Dropbox for health centers. We are keeping a Dropbox where we're keeping the critical information that you'll need. Again, that's www.massleague.org, the town hall follow-up. There'll be slides and recordings will be available in our COVID-19 Dropbox. The league will also have an FAQ developed and available in the Dropbox. Our clinical team is, quite frankly, 24 hours a day, 7 days a week, really making sure that they get the information that they need to get to you so that you have time to do your jobs and not have to search the web or monitor these websites and things. So please utilize these resources. And then the operation supports. We have very powerful peer-to-peer vaccine meetings in the vaccine community for community health center operations leaders. Please avail yourselves of these conversations. And then coming soon, supports for communicating with patients. We'll be providing you some best practices, what we're seeing that's working in our health centers, in other settings and across the country. And we'll be sharing that with you as well. I want to close it out by saying thank you very much for being on the call tonight. Thank those 500 or so people who took time out of their busy schedules to join us for this conversation. We have a lot more to learn, a lot more to understand, and a lot more to communicate. So I wish you and your families a healthy holidays, and God bless.